everyone. First, I want to thank Professor Penn and scientific committees for their invitations and allow me to share with you my recent research work in Singapore. So I'm going to talk about the Mendelian randomizations. So if we want to study the association between the risk factor and the disease outcome using a traditional epidemiology approach, right, there are always multiple confounders, right, between the risk factor and the disease, right? For example, in this case, I mean, the confounder can be either unknown confounder or what we haven't measured. So ideally, so basically, so if, for example, if we observe association between a risk factor and disease, it doesn't imply causation, right? Because basically, this association was confounded by many other factors. Now, let me give you an example. If we want to study the effect of nutrition on myopia, right, there's always other confounders such as outdoor activity, sunlight exposure, and so on. So how do we design a study which can tease out the causation between the nutrition and myopia? So for example, ideally, we want to assess the effect of omega-3 on myopia. We should conduct a randomized control trial, RCT. However, this RCT is not so feasible due to a few challenges. For example, there's always a relative long time to assess the treatment effect, right? And second, we also don't know what's the optimal dosage from the omega-3s. And the adherence to the intervention, in particular in children group, is also a challenge. So, but we know that we all know about Mendel's second law of inheritance. So according to this law, two alleles from the same genes will assert independently of allele from different genes. So that is allele that is transmitted from parent to offspring is randomly determined. And this is actually equivalent to randomized control trials. And so you can see that because of this randomization natures, right? So actually, each of the two alleles in a parent has an equal chance of being transmitted to the offspring. So in the RCT, the patients are randomized into either intervention group or the control group. Then we can compare the treatment outcome between the two groups. Whereas in a randomized randomization, alleles are randomized to two groups, and we can compare the outcome between the two groups to see whether it's due to the allele effect from alleles. So in MR studies, right, we use genetic variant as a proxy for the treatment effect. So we hypothesize that people who has the omega-3 rising alleles will have a similar effect as taking the omega-3 supplement in the RCT. So both of them lead to the higher blood level of omega-3, and that might modify the risk of myopia. So this MR design allows us to determine the causal effect between omega-3 and myopia. So in a randomized RCT, so if we want to estimate the effect of treatment X on outcome Y, actually we can use instrumental variables. And in this case, in the RCT, the instrumental variable is the assignment in the RCT setting. So basically, with the instrumental variables, we can the effect of X on Y can be estimated by the GY association divided by the GS association. So by doing this, we can get an unbiased estimate of the treatment effect. So when we apply this idea in the context of genetic analysis, right, we can replace the assignment with a genotype, and we can also replace the treatment with the so-called intermediate trait between the genotype and outcomes. And this is so-called the Mendelian randomization analysis. So now if we want to look at the causal association between omega-3 and myopia, what we need to do is just get a list of genetic SNP that is associated with omega-3, and also a SNP that is associated with the myopias. So by using this equation shown here, we can estimate an unbiased effect between the omega-3 and myopias. So basically in this work, we include the GWAS result from 18 fatty acids from the UK Biobank. And the fatty acids are measured by the target MMR approach. And this omega-3 basically is a subgroup under the polyunsaturated fatty acid. And we select 5 MR model to address the potential polytrophy effect and other analysis assumptions in the MR analysis frameworks to ensure that our results are robust. So we use about 20 to 15 SNP for the analysis. And this is a number of SNP we use for each of the fatty acids. And this is the proportion explained by the interventional variable in each of the fatty acids. So the slide shows the fatty acids are associated with a more positive 3-core equivalent. That is the low risk of myopias. So those fatty acids are the omega-3 to total fatty acid ratio, DHA, and so on. And on the other hand, this slide shows you the fatty acid, the list of fatty acids associated with higher risk of myopias, which include the omega-6 and omega-3 ratios. So basically, in summary, MR analysis suggests that higher omega-3 and HDL level are protected against myopias. And this is of public health significance because taking omega-3 supplement actually is potentially a very feasible approach for the children group. So likewise, we also use a similar approach and to study whether there is any causal relationship between omega-3 and AMD. We also found that the higher plasma level of omega-3 and DHL level are protected against AMDs. And in this work, we look at the association between the metabolomics and open-angle glaucoma. And we identify the HDL3 cholesterol is significantly associated with open-angle glaucomas. But we cannot find another cohort for the application purpose. So we use this MR approach to validate our finding. And the MR analysis again supporting that HDL3 levels is causally associated with open-angle glaucomas. So the second application of multi-omic MR analysis is the drug target MR approach. So basically in this approach, we selected genetic variants affecting gene expression level or protein level to simulate the drug intervention effect. So typically, genetic variants located in the cis region are chosen as instrumental variables. For example, we can include a SNP plus minus 100 kb within the gene boundary for analysis. But before you do analysis, we also do some quality control to make sure that we can get a reliable result. So let's take a reference from this paper published in Nature Human Genetic Behaviors. So basically in this work, the author integrated protein and gene expression data and conducted a drug-based MR approach. So basically in this work, they identify 3 proteins that affect the gene expression level in the brain and suggestion that these 3 proteins are the potential drug target to change the alcohol drinking behaviors. So in this work, basically the author also used a similar approach and they identify the A protein level in our plasma, which might affect the risk of POAG. And they also suggest these 8 proteins are the potential drug target for open-angle glaucomas. And the third application of multi-omic MR analysis is the mediation analysis, particularly when leveraging multi-omic dataset to tease out the direct and indirect effect. So this is quite straightforward because using this MR analysis design, actually we can just estimate the interrate effect and the rate effect. And the mediated portion just the interrate effect divided by the total effect. So using this approach, right, for example, in this paper, they look at the association between the gut microbiome and the risk of AMD. So basically, they found that, for example, this bacteria, Schleichia bacteria, can reduce the risk of dry AMD. And this was through the higher level of glutamine. And glutamine mediate the 70% of the association between this bacteria and dry AMDs. And just give you another example of the mediation analysis. Basically, we know that in high myopia cases, it's very difficult to diagnose glaucomas. So we also did an MR analysis to tease out whether there is a causal effect between myopia and open-angle glaucomas. So we showed that higher degree of myopia can causally link to open-angle glaucomas. And we also did the MR analysis based on between the bidirectional causal association between IOP and myopias. And through the mediation analysis, we also showed that IOP had the most significant mediation effect on the association between myopia and open-angle glaucomas. And the effect is much stronger than other variables such as nerve fiber thickness and the cup area and disc area and so on. So basically, this suggests that even we are not sure that whether a myopia patient has glaucoma or not, or no matter they have a glaucoma suspect or not. Actually, if we provide them with IOP-lowering medication, for long term, it still can reduce the risk of open-angle glaucoma. And this is all I have. Thank you very much.
If there's any questions on the floor.
Thank you, Cheng. That's always interesting. It was very clearly explained, the Mendelian randomization approaches. I'm wondering, from your perspective now, having really become an expert in this area, what you would recommend as kind of quality control or expectations from these kinds of experiments. So, I kind of have two general questions. One, what sort of effect size would you consider significant? Mm-hmm. And is that really related to the p-value? And what kind of cutoff, is a p-value of 0.05 actually significant in this setting? Do you need to correct for multiple comparisons for the number of SNP, vehicles that you're using? Are the SNPs that you're using, if you're using more than one SNP, are they all correlated or not correlated? Do you account for differences if they're correlated or not correlated? It's kind of a murky area right now in terms of deciding if something is significant or not in this kind of approach. I'm just curious what you might say to that.
Thank you, Jenny. I think it's a very good question. Actually, we see many more papers on the MR now compared to 5 years ago, right? Basically, because to do MR analysis, basically you don't need to collect your own data, right? You can just, download the GWAS summary statistic from the open source, and you can do a MR analysis on everything. But it becomes too much, right? So my current approach is that I use MR analysis as a validation tools to validate the association study from epidemiologists or from clinical observations. So by doing this, basically, the question we want to address, for example, the association between myopia and glaucoma, right? This is our clinical question. But we can use multiple approach to address, to validate these associations. So basically, I'm not suggesting we use MR for everything, right? You have to ask clinical meaningful questions before you want to do an MR. And my second comment is about what's the P cutoff we should use for the analysis. Basically, there's no consensus on this, right? So what I use that, for example, why there are so many different MR models, right? Because each of them have its limitations. Because each of them only address maybe just one of assumption, under multiple, one of assumption of the amount of multiple assumption under MR analysis. So what the approach I use that, for example, if you use five different MR model, you should maybe set a more stringent criteria, right? At least 3 of the 5 models showing significant p less than 0.05 and also the same durations, then we declare the significance. But again, there's no consensus what is better way to do this. I hope I answered your question.
And we may just have time for two very quick questions from Dr. Akiyama and Dr. Chakrabarty.
Okay. Thank you for the great talk. You showed the association, causal association of HDL3 on POAG.
Yes.
In the GBAS AMD, so we found many loss associated with repeat, but so we have written no about genetic association of genetic loci associated with repeat on the risk of POAG. So do you have any idea on it?
No, actually, we can discuss more about this. I didn't look into this, but it's interesting observations here.
Okay, thank you.
And a very quick one, Dr. Chakrabarty.
Question, like for instance, in MR, when you're looking mostly into the causality, and these are largely based on cross-sectional data, right? You are taking GWAS data and you are taking the phenotype data at that point of time. But these are actually progressive data, like when you talk about myopia, when you talk about glaucoma. So how are these adjustments done at a later time? Because the cross-sectional, actually, it should have been longitudinal, but in cross-sectional also you can predict a longitudinal outcome.
But basically this is also the same issue with all the GWAS analysis, right? Because our phenotype change over time, but our genotype is fixed at birth. Right, so even it's cross-sectional data, basically, when you look at genetic association, basically, it's more like the perspective, right? Because the genetic, the risk factor already fixed at birth, right? They won't change over time.
No, the germline changes are fine. I'm talking about the clinical data, which is progressive. Because there also, let us say if we take GWAS data, we're taking only at that point of time when the individual has been sampled, whether he had the phenotype, milder phenotype, moderate phenotype, right? But over a period of time, that phenotype can change. So in MR, how do we adjust for the longitudinal outcome?
Well, this is an interesting comment. Actually, we haven't looked into this yet, but I believe this will require some new method for this type of MR analysis.
Thank you so much, Dr. Ching.